Good afternoon, everyone. We are back again to talk about another controversial topic of robotics. Where do we stand? And that too to a country where it's very less than because of obvious reasons. So, we talk about robotic bariatrics. We get into the background, the no disclosure as such. The use of robotic platform in bariatric surgery is gaining momentum for the last 4 years in a very big way, especially after general surgery. Robotics has gained so much of popularity. Of course, with annual growth of 2.2% for primary and 2.4% for revisional bariatric surgeries robotically. And the adoption of bariatric surgery still remains controversial, so just want to discuss on data available to see where we stand. Again, contradicting clinical evidence due to the procedural bias. That's very much because most of them are all retrospective and there is no level 1 evidence still available regarding robotic bariatric surgery. And of course, considering the increased healthcare expenditure, and that is one reason why I think UK has not caught it up as well as well. Just to start the history, evolution started from 1999 when Da Vinci started the first system to now X5, which is supposed to be one of the best personal experience wise. Definitely it is going to take robotic surgeries into a much bigger way. But the introduction of staplers in 2003, it started gaining a little bit popularity, and then with Transcentrics trying to work with much more platforms in 2016, and then CM introduction from UK in 2018, and then Medtronic in 2021, 2022, it really opened up the floodgates. With the introduction of 60 mm sure form staplers by Da Vinci has made a true robotic surgery possible, and since then robotic bariatrics have gained huge popularity, and that's when it started growing big time. This is a typical global utilization of robotic surgery as of now. US stands first with 19%, rest all 5% in the Europe and 3% entire globe as such. And India is about less than 1%, Australia is around 3%. This is the global utilization of robotic surgery. And of course, we have 4 major platforms now available for the world, except for China, where there are 6 already existing one, but which is not outside the country. So we have Da Vinci system. We will come into the mechanism of each where we stand. So then we have the second system which came into big practice. Transcentrics started coming in, but not a big way. CMR Surgical with their Versius. Then we have Hugo Ross with their, Medtronic with their Hugo Ross, and then an Indian company we're proud to say, which is SSI Innovations with their Mantra Robo, are the 4 clinically available robo across the globe for soft tissue surgeries. Now, where we stand with regards to the surgeon's console, what we use, we have an open console and closed console. One is using 3D glasses, one is that closed console is immersive glasses, and we don't have a true stereoscopic 3D with the polarized glasses because we see to the camera in a 3D, but polarized due to the 3D glasses. In the immersive one, we have a proper stereoscopic. There's something called as vergence accommodation conflict. We operate somewhere, but there is a distance between eye and the monitor, which is going to be a conflict between the visual and the accommodation side, which is pretty much good in this. So as of now, the closed console is much better. Whenever you want to buy a console, try to find out a closed console wherever possible. But then again, reduced vision in an open and a better vision, because field of vision is much more bigger in a closed. But the biggest advantage of our open side is increased spatial orientation. We are used to the orientation of the entire ecosystem of the OT, which is going to be similar in an open, which is going to be a problem in the closed one. And of course, adaptation is much faster. Like standing between the legs, you can become an advanced lap surgeon after Cody than standing on the own side. So that's why adaptation is much better. That's how a lot of people are going towards open consoles nowadays. Where we stand with the arm cart, we have 2 kinds of arm cart. One is a forward docking and reverse docking. Da Vinci is the classical reverse docking. Integrated arm called a boom, which has 4 arms in it. Ergonomical stability is much better with this. That means what we call as a fixed fulcrum. can fix a fulcrum, and accordingly it doesn't move much, so the pain is much lesser because the trauma is much lesser, and less space occupying because from one boom is coming around, and increased conflict of working space because all four come from one place. But then again, with the X5 now, what happens is we fix up a distance of 3 to 5 centimeters between both the arms. The arms move themselves with the fulcrum fixed to the trocars. So fix the trocar and then ask the arms to move out. Then the surgery becomes much easier for a multi-quadrant with the X5. That's where we stand with regards to technology, which is really, really amazing. And then the only problem is a uniplanar plane. Either you are above operating, either above the trocar or below the trocar in one plane. We cannot cross the plane. Whereas in a forward docking with the multi-arms, we can economically decrease space occupying, decreased conflict of working in place because we move the arms completely away from each other, and multi-planar surgery. One or two can be docked forward, one or two can be docked reverse, so we can operate both the planes if you wanted to do much. But then again, there are a lot of difficulties with that. I will come to that later. This is the arm dynamics, what you're talking about. So anybody who are buying a robo, and should understand this, human hand has to replicate the robotic arm. 400 mm of shoulder offset, which is possible in a Da Vinci and Figueras, not in a CMR technology. 430 centimeter of your arm replicated through again, but here also is replicated in all the three parts. And forearm of 380 again replicated, and effective length of 1 meter is with 190 mm of hand is replicated. But the only difference is, you see here, this is called as the RCM, remote controlled motors. So mechanical RCM is this move completely in and out around the fulcrum. The same happens in Da Vinci and Figueras, and SSA Mantra started like this and moved out. So what happens if you want to exchange the instrument? You just move the mechanical arm out, remove the instrument. Whereas in the CMR mechanism, you remove the entire arm, displace the entire fulcrum and go back again. It's very difficult to do instrument exchange. So this mechanism should not be bought anywhere when you want to do a advanced surgery, and this is why you don't find too many bariatric robotic surgery done through CMR. And the instrumentation wise, where we stand is we have 7 range of movements against 3 range of movement in laparoscopy, from rotation to pitch to yaw to distal yaw to grasp and distal pitch. So we have 7 range of movements. All 3 precision, dexterity and control is there. And then with the advancement, with tremor filtration and motion scaling, the dissection technique is going to be much useful. And then with the advent of the sure form staplers, which is the only company, Da Vinci is the only company right now have robotic staplers. A true robotic surgery is much easier with what we call as a cone articulation. 270-degree articulation all around make life much more easier against a 45-degree left and right and in and out when it comes to regular available staplers with us. Access wise, there is a small change in the ergonomics. That is what need to be done, which was not learned initially well. That is where a lot of complications happen in robotic surgery. So in normal laparoscopy, around the fulcrum, we have a 2 centimeter distance between the telescope and the abdominal wall, and then the instrument comes to which is 3 centimeters. So around 5 centimeter distance is good enough. In a robotics, there are 2 junctions, and there is a fixed fulcrum area which is about 3 centimeter into the abdominal wall, and again one junction is another 2 centimeter, and then the second junction is another 3 centimeter. So there will be a 3 to 5 centimeter extra length needed. So instead of normal laparoscopic port placement of 15 to 18 and 18 centimeter, you do 18 to 20 centimeter. Instead of 6 to 8 distance between the telescope and the working arm, you do 8 to 10 centimeter between the arms so that they don't clash. And that's the ergonomic modification which we understood in the last 3-4 years, and that is why again robotic bariatrics are picking up much more with less complications. Now we did a beautiful MBS study about 130,000, 88,000 patients or so, and found out what is exactly is the advantage of robotics in primary bariatric surgery. It lowered the complication rates, including leaks, hemorrhage, and stricture. Replicate economical advantage with lesser operating fatigue. So that means a lot of surgeons can easily be doing robotic bariatric surgery, even a novice surgeons can be doing it. And reduced length of stay and period of inactivity. Decreased incidence of acute kidney injury and venous thromboembolism compared to laparoscopy. Shorter learning curve, again both for novice and advanced surgeons. Longer or similar operating time depending on the type of procedure. If you do a sleeve gastrectomy, it is longer. If you do a bypass surgery, it can be longer or equal. And additional cost to the patient with regards to the time and the platform, but there is a significant decrease in the operating time and readmission with years. So that's what it is shown. Mostly the MBS A-Cube and then other interesting studies which all compared a lot of 28-30 publications of this. When it comes to revision bariatric surgery, where they compared close to around 30 or 40,000 patients by the MBS A-Cube, advantages in operations involving reduced, fixed and deep operating field. So when there is a deep operating field, lot of adhesions around, then it's more advantageous by doing a robotic bariatric surgery, and lower complications during more complex. Maybe if you are converting it to a SARI, converting it to a DS, then it's more advantageous with lower complications. Significantly less post-operative C-reactive protein, which doesn't, for first couple of days, is much lower C-reactive protein as well. And of course, lower conversion and readmission rates in robotic bariatric surgery, assist in significant increase in revisional surgery. So the chances of revisional surgery has increased after the advent of robotic bariatric surgery, and common to use in more complex revisional procedures as such. A lot of SADIs and DS started happening in revisions after robotic came in, and non-inferior outcome with regards to the percentage excess weight loss compared to laparoscopic revision. And but the problem is most of them are retrospective studies with a procedural bias. Then we talk about super obese patients, because these are three areas where they say robo is better. When it comes to super obese patients, significant longer operating time but reduced length of stay in the super obese. But when it comes to super obese, beyond 60-65 BMI, comparative operating time and costs in these patients. This is about some 12,000-14,000 patients who the MS, MBS, ABQ as well. Yeah? One more minute. So, then greater control of the surgeon and reduce risk. Maybe I'll take a couple of minutes more and go fast. So, clinical evidence-wise, there are plenty of studies. I just got to say there's strong clinical effectiveness and evidence base to say robotic surgery is much better. But again, the biggest advantage is with regards to the musculoskeletal disorder on the surgeons. There is very less interest shown on this part, where the surgeon has up to 6.35% of them undergoing surgery and close to 50% of them starting medications for their musculoskeletal disorders. And this is an interesting study by RSA where so much of a problem the surgeons face, and there is plenty of significance when it comes to years of practice. The more years of practice, the more chances of MSD. And again, height-wise, age-wise, gender-wise, there is significance. And robotic again shows much lesser rates of MSDs than bariatric, laparoscopic surgery. And learning curve-wise, there are plenty of studies that come into practice, published, which shows robotic surgery has a short and insignificant learning curve. Novice and expert surgeons have similar learning curve. The stabilization of a learning curve between 10 and 30 procedures for surgeons and 5 surgeries for bedside assistants. But when it comes to reality, what exactly is happening? This is an interesting data by IFSO in the 8th global registry, where only close to 2% of patients undergo robotic bariatric surgery against, others, all other, even open surgery was less, but then robotic is much lesser, couple of minutes maybe. And then adoption of surgery by various countries as per registry, CUK 1.2% and 1.5% for revision surgery. So adoption except for USA, everywhere it's much lesser, it's 1, 2.5% and stuff like that. So then I went back and saw a lot of interesting different data on by FDA approved publications shows existing evidence of questionable benefits when it comes to robotic bariatric surgery, emerging evidence of potential harm, diffusion of cost to patient premiums, insufficient surgeon credentialing, and poor transparency and informed consents. Then effectiveness across platforms, except DaVinci, any other platform, technology is still evolving, non-availability of special instrumentation, need for 2 dedicated surgeons, and limited portfolio of surgeries, and that is why it is not gaining popularity. Health technology hazard by what ECRI, one of the biggest non-profit organizations in the US, of the 10 health hazards of 2020, number 5, unproven surgical robotic procedure may put the patient at risk. So when they compared lakhs and lakhs of data, there was no significant evidence to prove robotic surgery is superior to laparoscopic surgery in most ways. In our series, we had 88 surgeries from DaVinci and Vigoras compared to 1,600 odd surgeries laparoscopically, with 5% of our surgeries being robotic. Again, cost is one problem why we did that. When it comes to significance, pain score is significant, and otherwise time is high. Time is significant in the case of laparoscopy. Average length of stay is not significant. Comes to complications, overall complications not significant. Again, leak, stricture, bleeding, nothing is significant when compared. So where we stand today, as of now, platform-wise, open, closed console, and unicard, multicard, both has its own advantages depending upon the surgeon's motor and mental access. You can always work on it. Docking and arm dynamics are a bit difficult. Instrumentation are good, but the specialty instruments of stapling, vessel sealers are not there. So most likely, except for DaVinci, 2 robotic, and the cost being very high. Otherwise, it becomes 2 surgeons operating and increased cost and operating time. In the procedure, learning and unlearning is okay. Technology enhancement like ICGs not very helpful for bariatrics. Nerve vessel sparing tumor clearance have no role in bariatrics. Task performance is pretty good. Outcome measures are similar to laparoscopy. With so much of a cost of 230 times more than laparoscopy, maybe we have to think twice as of now. To conclude, robotic platform is still an emerging technology. Most surgeons have not met with the learning curve. They say around 70% of surgeons are not met with the learning curve in robotics, even though they perform robotic bariatric surgeries. Outcome reports and literature may fail to reflect the real advantage, that because they are not learned in the right way. Major drawbacks are prolonged operating times and higher costs. Learning curve is delegated to the increased operating time and cost. The use of robotic technology in bariatric surgery will still remain controversial. Cost and long-term outcome measures to make it a meaningful outcome. Thank you.
Thank you. I'm going to make just say something. This was only after yesterday. I just picked some data up as well, just to see what your comments are. There's 2 papers published from San Diego. I only saw this yesterday, so don't believe what I said. They think total robotic surgery has been shown to have shorter operating time, lower length of stay, and reduced complications. This is total robotic surgery,
yes,
not robotic assisted surgery.
Yes. So total robotic surgery, yes, that is very true. But again, it's all retrospective by studies. There is no level 1 study as of now yet. So when even total robotics, which is happening for the last 3-4 years, the learning curve is coming down, the time is coming down drastically. Very few centers, shorter one. Otherwise, it's almost double the amount of operating time coming down close to. So that means in a few years, maybe in a couple of years, 3 years down the line, it becomes truly a shorter operating time than laparoscopy.
I don't think you understood it. They've already shown that compared to laparoscopic surgery,
I agree. It's an independent one study, retrospective study of one. We need to do a long-term level 1 study approval on that to say robotic surgery is here to stay. That's why I never picked independent studies. I picked mass studies where they have 100,000 surgeries and analyzed.
Mr. Chairman, can you have a mic, please?
I think the advantage is when you get old, you sit in operation.
See, I personally enjoy robotic surgery, but then the data shows.
Definitely the time taken is more. Obviously, like when you start laparoscopic surgery, I remember the first bariatric surgery done in 1999 or 2002 in England. It took about 3-4 hours, but then it came down, maybe 35 minutes, 40 minutes. So I got a gastric bypass. So things are improving. It evolves over a period of time. I agree on that. But definitely useful for people who are still interested in operating when you get the word constant for long. Sit on operating. Better learn it now.
Thank you.